Hi, I'm Casey Lloyd, and this is my respiratory and cardiac assessment. Before entering the room, I would have washed my hands, confirmed that this patient was indeed Mr. Lloyd, and confirmed his date of birth and patient identification. Now, typically, I'd have him disrobe, but since it's cold in the full house, we'll let him keep his clothes on. Initially, I'm going to inspect the patient. I'm going to notice their work of breathing, their respiratory rate and depth. Are they using accessory muscles? Are they using their belly to breathe? Is their nasal flaring? Right now, his respiratory rate is somewhere in the 16 breaths per minute range, probably a little quicker because he's on camera and a little bit anxious about it. From there, I'm going to look at his chest and notice any abnormalities, any deformities in his chest wall. Assess his chest from the side to see if there is any abnormality in his chest formation, such as a convex or concave chest. From there, I'm going to palpate with my fingers across the chest wall and the front and the back, looking for crepitus or any kind of grating vibrations. Then I will move to percuss his lung fields, beginning in the first intercostal space, hoping to hear symmetrical resonance across his lung fields. I'll meet dullness or tympany of his abdomen. I would also percuss his posterior lung fields. Hoping to hear resonance. I'll turn sideways. At this point, I would use my thumbs, placing them at the costal angle. Ask him to inhale. Take a big deep breath and exhale. Noticing the movement of my thumbs, watching to make sure they're symmetrical. I would also use the ulnar aspect of my hands and ask the patient to say 99 as I move down his chest fields, lung fields. Say 99.
99, 99, 99, 99, 99.
Hoping that vibration, let me do that first, is symmetrical. Go ahead.
99, 99, 99, 99.
From there, I would measure his diaphragmatic excursion, asking him once again to turn sideways. He's a good patient. Asking him to hold his breath in while I percuss down till I meet dullness. Marking that with a pen as he holds his breath. Okay, exhale. And then exhale and hold it. Now percussing upwards till I meet resonance again. Marking that point to find the measurement of diaphragmatic excursion. At this point, I would auscultate his lung fields. Asking you to breathe in as I move my stethoscope. Listening for any abnormal breath sounds, such as wheezing, or rhonchi, or rales. Listening laterally. Now I would ask the patient to say 99 again as I listen.
99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99.
Then I would move to the cardiac part of the examination and ask the patient to lie supine. In this case, we really don't have a great place to do that, so we're just going to assess and pretend he's lying supine. At this point, I would inspect the pericardium, looking at the chest wall for any vascular abnormalities, for any heaves, lifts, or thrills, any pulsations that would be impressive to see just with the eye without palpating. Noting the sternal border, beginning with the second intercostal space, I would palpate to attempt to feel the aortic valve, moving mid-clavicular on the right side, or the just second intercostal space here, pulmonic, attempting to feel any lifts or heaves, then moving downward to the Erb's point, and then more mid-clavicular, apical, down to the fifth intercostal space, where we would expect to find the PMI. From there, I would move to listen to the patient's heart tones, listening over the same valve points, listening to the tone and pitch of the heart sounds, assessing the rate and rhythm, noting any murmurs or blowing sounds, any clicks or gallops. And I would have palpated the apical point earlier and counted the heart rate. And that concludes my assessment.